We're going to start the next session now, albeit half an hour late, but I think we'll make up some of the time. So the next session is common oculoplastic surgeries. It's a vast session. I thank Dr. Fairuz for putting this together. So first I'd like to call upon the stage the chairman of the session, Dr. Anita Sethi ma'am, and co-chairman Dr. Mukesh Sharma. So the first talk that we'll have is an approach to a patient with epiphora by Dr. Alexandra Levitt. Hello. So Dr. Alexandra has come all the way from the US, and she'll be talking to us about the approach to a patient with epiphora, and after that we'll have Dr. Ruchi who will be talking about external versus endo DCR, and we can have a short discussion after that for the lacrimal surgeries. Please go ahead.
Thank you so much for having me. I'm really happy to be here this morning. The goal of this talk is basically a broad strokes overview of the evaluation and management of patients presenting with epiphora. What patients are we talking about? Dealing mostly, focusing on adult patients who present with epiphora or frequent mattering, may or may not have a history or exam findings suggestive of acute or chronic Dacron cystitis, but we're not really delving too deep into more complex underlying pathologies, tumor, etc. It's really important with these patients to fully evaluate them for any concomitant comorbidities because they may require management at the same time. As you all know, tearing is a complex and a multifactorial issue, and so these patients kind of demand a holistic approach. Things like, for example, eyelid retraction or laxity, which can cause reflex tearing, but additionally lacrimal pump dysfunction if there's significant laxity. Patients with ocular exposure from poor blink or lag ophthalmos from a variety of causes, ocular surface disease, dry eye, paranasal sinus disease, all of these are things you need to be aware of in the management and evaluation of these patients. In terms of physical exam, things to look for, any sort of conjunctivitis, lid margin disease, blepharitis, ocular surface inflammation or infection, doing a comprehensive corneal evaluation with fluorescein staining, looking at tear breakup time, and generally evaluating the patient for dry eye, which could cause reflex tearing. Looking at the tear lake height and any asymmetry between the two sides, assessing lower lid malposition, laxity, retraction, ectropion, entropion, and paying particular attention to the punctum, looking for stenosis or punctoectropion, which could be contributing to their symptoms as well, and require specific procedures to address those issues. After this external examination of the ocular adnexa, then some assessment of lacrimal outflow, which we'll talk about in a minute, and you could also consider in-clinic nasal endoscopy as well. What's really important with these patients is differentiating outflow obstruction from tear overproduction issues, identifying if there's multiple etiologies so that they can all be addressed appropriately. In terms of evaluating lacrimal outflow obstruction, there are a few different strategies for this. The most simple, installation of fluorescein dye and looking for clearance. You can also perform a Jones 1 test where you would assess the inferior meatus for the presence of fluorescein dye after 5 minutes, or finally canalicular irrigation and probing. Regarding the fluorescein recovery, after installation in the eye, within 5 minutes, this should be appreciated within the nose, and you can either insert a cotton-tipped applicator or cotton swab to check for this, or you can visualize directly with an endoscope or have the patient or simply just blow their nose. And there is a false negative rate associated with this, so you may consider performing this on both sides to ensure accurate testing. Lacrimal irrigation is a really valuable examination technique as well, typically performed with a 23 or 25 gauge blunt-tipped cannula that should be able to be easily inserted into the punctum. Some water or saline is flushed through the canaliculus, and the patient would report when they feel it in the nasopharynx. This gives you valuable information on stenosis or obstruction, looking for reflux or mucoid reflux, and also an assessment of the canaliculus, canalicular stenosis, punctal stenosis, anything that makes for difficult cannulation with this relatively thin cannula may be clinically significant in terms of the epiphora the patient's having. Once you've completed the examination, then you can kind of focus on the specific anatomical issues that may be causing the patient's symptoms. We'll focus primarily on nasolacrimal duct obstruction and options for surgical management. Just to note, though, that often these patients are in a gray area where you have patients who complain of epiphora, but they don't really have a history of dacryocystitis. They're maybe partially obstructed when you irrigate them, but eventually some saline will pass through, maybe some lid laxity or malposition, but nothing, not a clear black and white picture in terms of what exactly is causing their symptoms. And just to note that it is, totally appropriate in these sorts of cases to take a stepwise approach, starting with the least invasive, topical steroids to address reflex tearing, progressing to minor in-office procedures like a medial spindle atropion repair or punctoplasty to see what improvement can be gotten there before progressing to formal surgery. In terms of surgical management options, starting kind of from the least invasive, progressing, up to DCR. As you know, probing, very successful in congenital NLDO, really not so much in adults. With the addition of mitomycin C, the success rate of probing does increase, but the results are still relatively underwhelming from that. And generally, think about that as potentially an option for patients who aren't candidates for surgeries. This can be done, in the office, theoretically, if they would tolerate it. A bit about mitomycin, as you know, used in many ocular and oculoplastic procedures, and antifibrotic and chemotherapeutic agent, but basically helps to mitigate scarring and restenosis after recanalization of the nasolacrimal duct or the creation of an ostium in a dacryocysterinostomy. Progressing from just probing with or without mitomycin to silicone intubation, again, relatively underwhelming results long term. The success rate of stenting can be increased by leaving the stent in longer and double stenting as well. But mitomycin may or may not be helpful depending on the duration of their symptoms. Adding dacryoplasty to intubation, again, not really significant improvements in terms of long-term success rates. So just a summary for non-DCR procedures for adult nasolacrimal duct obstruction, and those would be probing plus or minus mitomycin, silicone intubation, plus or minus mitomycin and balloon dacryoplasty, kind of topping out in the 60-65% success range around a year, which for most patients and most surgeons probably not really acceptable. DCR is really the gold standard for lacrimal outflow obstruction. Basically, as you know, you're surgically creating a passageway, anastomosing the lacrimal sac into the nasal mucosa, bypassing any sort of nasolacrimal duct obstruction. Two major approaches, external versus endonasal. External has been around, for over 100 years. Endonasal becoming increasingly popular, especially because the lack of a skin incision. In terms of external, two different typical locations for skin incisions noted here. I won't go into too much depth. I think someone is speaking on external versus endonasal DCR later in the session. But in general, kind of a gold standard surgery, very successful. The external approach does give you a good view of anatomy. It could be done under conscious sedation, anesthesia. For patients who aren't a candidate for general anesthesia, does not really require any special equipment. Major disadvantages, cutaneous scarring, possible, usually transient orbicularis weakness that may affect lacrimal pump function, and then a little bit more post-op bruising and swelling, although that typically does resolve within the first 7 to 10 days. endonasal DCR, many different approaches to this with various ways that you can be assisted, and the success rates really are pretty comparable to external. Post-op management considerations, I think everyone has their own regimen for this. Typically, we would have patients on antibiotic steroid combination drops, tobramycin, dexamethasone, or similar for 1 to 2 weeks. Intranasal steroid spray such as fluticasone for about a month or so. Not in all patients, but sometimes performing irrigation in clinic 1 to 2 weeks post-op to clear the ostium. And then if a stent is placed, usually removing it around the 3-month mark. Is stenting necessary? Many studies have looked at this with many different results. A large meta-analysis showed no benefit to silicone intubation with DCR. A more recent meta-analysis did show a marginal benefit. So I'd be interested to hear what everyone's personal approach is and philosophy in this situation. Take-home points overall, for patients with epiphora, canalicular irrigation with palpation of the lacrimal sac can provide excellent diagnostic information and really is very easy to do and painless for the patient. For patients with epiphora and an otherwise normal exam but evidence of complete NLDO, DCR will help at least 90% of them, potentially more. But if there are concomitant comorbidities, lower lid laxity, et cetera, those should be addressed at the same time. And then overall, for epiphora adults without active dacryocystitis, cystitis, silicone intubation, moderately successful, can increase the success rate slightly with mitomycin, but would think of that in general in patients who aren't surgical candidates. And for people with adults with complete NLDO obstruction, external DCR and endo DCR are both very successful surgeries alone, and mitomycin again can be a useful adjunct. Thank you.
Ma'am, your mic.
Oh, sorry. Thank you. That was a very comprehensive overview of the management of epiphora. Just a question. The candidates who are not surgical candidates, then what of the non-surgical, what do you prefer? Like you gave us some suggestions. Do you use any of them or what do you prefer?
I personally haven't performed mitomycin irrigation. Usually, in my experience, the patients who aren't great candidates, it's an anesthesia concern, and so I have done an external DCR under monitored anesthesia care, which can mitigate some of the concerns, especially patients with cardiac pathology. I've had some success with topical treatment as well, like fluoromethalone drops. I mean, it really depends if they have a complete nasolacrimal duct obstruction. Obviously, that's not really going to do anything. But if you can mitigate all of the other factors that could be contributing to tearing, I find that helpful. I have tried lacrimal gland Botox, which I'd say underwhelming. I probably wouldn't recommend that. But
we're looking at the cases where there is epiphora and we don't have any other treatment. So it's, as you said, multiple reasons, so you try to address as much as you can.
Exactly.
Yeah. Okay. I think we can discuss the rest after the other talk.
Yeah?
Okay,
So,
thank you.
Yeah. Next we'll have Dr. Ruchi Goish, and she'll be talking about external versus endoscopic DCR.
हाँ प्रीव्यू रूम
अभी आपके पास पेन ड्राइव होगा?
ओह सब अपलोडेड है यार मेरा उसमें देखो चेक करो मैंने अभी तो कराया सब कुछ चेक भी कराया उन्होंने होगा ज़रूर होगा It's not reached from the preview room here. I'm just
अब एक मिनट मैम कौन सा है?
While we have a lull, we can maybe
एक्सटर्नल versus
Yeah.
you can take maybe a
So-
question.
खोल दीजिए इसे पूरा.
So with respect to the stenting that Dr. Levitt
We
also
have
mentioned.
epiphora in cases of aging and also with lot of screen times now. Even youngsters do get, that is epiphora, not actual epiphora, but do we have watering and all that? So how do you manage those things?
So I guess a lot of that is attributed, especially in young patients, would be attributed to dry eye, etc. But we'll just let Dr. Levitt also answer that.
Sure. I think a good question, and that kind of recalls the idea that these are multifactorial problems. Obviously, subjecting a young person to invasive lacrimal drainage surgery isn't going to help them if their problems caused by dry eye. So I think really comprehensive clinical examination. Also, the history I think is really helpful in these cases. Some patients will even volunteer, oh, this problem only happens when I'm working or watching TV, or I'm outside and it's really cold and windy. And those kind of clue you in on potential ocular surface concerns. And I'm usually, I'm very ready to start conservatively. And so it's frequent that I'll have patients use topical lubrication plus minus a topical steroid. And in a lot of cases, that will be enough to solve their problem. But a great question.
Thank you. Yes, please.
Sorry for the delay. Actually, I had uploaded. I know what went wrong. Anyway, so there's a lot of discussion about the external and endoscopic. I'm not here to say that which one is better. I still agree that external DCR is, that's the best procedure because it can tackle all kinds of patients, which sometimes the endoscopic DCR will not be able to tackle. So again, we all know about these differences, when to choose what. So my main emphasis will be like whatever you're doing, external or endoscopic. One thing is that you should do a very good nasal packing, especially in endoscopic DCR where if you have bleeding during the surgery, you need to abandon it. So please focus very carefully on that, and a good nasal packing for external DCR. When we are doing an endoscopic DCR, we do the packing using an endoscope right at the knuckle of the middle turbinate. So I'll just show you. The other thing is the anesthesia. When you're doing external DCR, I think most of us are doing it under local anesthesia unless the situation balance, like it's a pediatric age group or whatever reason. But when you're doing an endoscopic DCR, it is always much easier when you have a general anesthesia because you need a very good a bloodless feel and a very cooperative patient. Otherwise, the blood keeps trickling and you have gag reflexes and all kinds of discomfort. But again, India, as we all have issues with the GA, lots of us end up doing it under local anesthesia also. And remember that you must give your good anesthesia and tackle the maxillary branch also, because this is the area where especially when you're doing an endoscopic DCR, this is the area where you're going to work. Now I'll just show you a couple of cases which are more suitable for external and some cases which are more suitable for endoscopic DCR. So here, whenever you have patients with trauma where you have to repair the telecanthus, you have fractures, you have a lot of other things that need to be addressed, and your landmarks are lost. And whenever you have fractures, you don't have those typical landmarks that your bone is going to break from here. Your sac may be displaced. Now look at this case. I couldn't see the medial canthal ligament. Look at this sac. It is very badly stuck to the area adjacent to it, and at times you don't even find the suture line where to break. So here even your old hammer and chisel comes in handy, and you need to put back this medial canthal ligament back to the periosteum. So this is a hammer and chisel which sometimes comes in handy where you have these fractures which have been repaired, or sometimes they get ossified on their own, and this bone will not break whatever you do. So these are the patient I would always go in for external DCRs, and I'll just fast forward the videos a little. So and of course whenever you have part of the sac missing, then you can take, you can always on taking a very large mucosal flap, which you cannot do if you are doing an endoscopic DESA, where because of limited field these maneuvers at times may not work out for you. And this is just how you suture back your medial canthal ligament and address the telecanthus. Now this is another technique, very nice technique. Suppose you don't have hammer and chisel, a lot of youngsters wouldn't even have seen a hammer or chisel lying in the set. So you can always, this is a burr which is always there for your orbital decompression. So you can make use of this this burr and create osteotomies whenever you don't find those suture lines, and this really works well. Only thing is you need to be careful to stop the burr and don't burr through the mucosa. So the trick is just pull out the nasal mucosa flap when you are doing the burring, so that the mucosa tends to fall back into the nasal cavity. Now a short clip of the endonasal. Now we are doing an endoscopic surgery. Remember, this is your middle turbinate and this is the root. So your opening has to be slightly above, and it's going to go down to around the anterior maxillary line. So your incision, remember, has to be starting above it and not below it. So if you have a this long incision, and it has to be, again, very important is that you have to put in soaked Merosil with adrenaline. And whenever you have patients who, if you have patients with heart disease, especially older patients, and you put in a lot of adrenaline, it is not a good idea that you do it without the help of your anesthetist there. So these patients, because of I've seen patients going into ectopics and all that, so you need to be very careful when you're doing backs with high amount of adrenaline. And this is this is what we use is powered endoscopic DCR, where we are using a burr to chisel out the superior part of the cavity, where the bone, the maxillary bone, becomes very thick, and then you gingerly take out pieces of the bone. And once the sac is visible, this is the sac flap being this is a mucosal flap, the sac flap being made, and you can see the mucosil getting ruptured and the fluid coming out. And you can always check the opening of the common canaliculus by irradiating it. Now these flaps, I don't like to suture or do anything. We just put them back in a form of a book and leave it alone. Now laser DCR is especially useful when you have laser, or maybe any of these endoscopic procedures. They are especially useful if you have acute cases where if you have, your skin is excoriated and you are not able to give an incision there, and even if you give an incision there in a excoriated pus, there is a pus oozing, you may end up into orbital cellulitis, and this infection may even cause a non-healing type of a wound. So here these endoscopic procedures, they come in very useful, where you simply, this is a laser DCR which I have shown using a diode laser, and here you just through the canaliculus you create a small osteotomy. I have actually done a study where we did it in stages, where in the first stage we simply made a small osteotomy, and this small osteotomy, it stands like an incision and drainage. So instead of doing an incision and drainage, you simply create a small osteotomy, just leave the patient alone for a while, and the patient dramatically recovers in next few days, and then you can actually go for whatever procedure you want to, enlarge it surgically, which I'll show you how it is done. So after creating a small osteotomy, this is you can just use a Blakesley's forceps and enlarge this opening to about 8 to 10 millimeter, or you can also go for external DCR by simply just creating that osteotomy. The advantage again is that the drainage of that pus is now occurring within the nasal cavity, and you have not, otherwise sometimes by aspirating, what we usually do is we take a cylinder needle aspirator and do an IED, that causes permanent fistula formation. So we have published this also, our results, and we have shown that this is a very good technique and it works. But laser DCRs, they have this disadvantage where if you have a burnt tip, because laser DCR fiber optic has to be in good health, otherwise you can have these kind of burns, and they really are very disfiguring. And thankfully this patient healed, and ultimately I had to do a conjunctival DCR for her. Now there would be cases where there would be like, this was a dermoid cyst sitting on the nasal sac. So here again there is no role of endoscopic DCR. I had to take out this dermoid cyst and then do a DCR. and then this patient has recovered completely. So always, whenever in doubt, not every swelling over here is a mucocele. So just be very careful whenever you are in doubt. Always go in and get a scan done, and then plan your procedures. Again, a patient with trauma, and you can see there is a lot of scarring over here. You have a granuloma here. So again, there is no role of endoscopic DCR in this patient, and you see that the canaliculus is also damaged. So I have just put in my probes to secure whatever canalicular area is intact. You need to have a large, long mucosal flap again in these kind of patients, where you can just cover it and suture it just close to the common canaliculus, which you can see internally. So patients where these patients they also have sometimes fractures, and you may not have a very good nasal cavity to put in your endoscope, and otherwise you need to take help of your ENT colleagues first. Sometimes you have to do a septoplasty and all those procedures, and then you can do an endoscopic DCR. So as I said that you really now this is of course again a patient with common canalicular block, where we have shown that retrograde intubation. Suppose not all patients would require a conjunctival DCR. Suppose you have about let's say till 5 millimeter of your canaliculus intact, then you can do a retrograde cannulation, and this is a common canaliculus. You give a vertical incision into the sac, identify the common canaliculus, the same Bowman's probe which you use for I've just bent it about 8 millimeter from there, and you bring it back, and you can intubate your patients. If it is a common, this opening is blocked both upper and lower, I usually avoid this procedure. But if one is intact, the other one is not intact, then this really works well, and you can do a good bicanalicular intubation also. And these are of course the OCT pictures and post-op results. Then coming to the conjunctival DCRs, the external conjunctival DCR is extremely easy, because here you have a good exposure, and remember here the osteotomy size has to be smaller. You don't need very large osteotomy size, because the tube otherwise tends to keep moving, and you want a snugly fitting tube which is abutting the bony osteotomy. So here you can directly visualize through the this is the caruncle, and you can visualize and you can put in your tube, and it's easy to fasten this tube to the tissue along here, because you can take, even if there are no eyelets, you can just take a round all around, and then you can fasten it inside the wound. But when it is and you can see on table there is a very good drainage that is occurring. But when you are doing this endoscopic DCR, it becomes difficult. So I showed a procedure where you could fasten this tube. This is a mirror tuck technique, and this is an endoscopic DCR being done. So you simply through the caruncle you create an osteotomy, and the advantage here is that you can directly visualize the tube inside the endoscopic through into the nasal cavity through your endoscope. So it gives a exact location of the tube, whether it is in correct position or not, and also you can see. So you can check the tube location and also the size of the opening that you have created. So this is the mirror tuck technique, where you just this is a tube. You can see the tube is very nicely fitting, and it is there, and this is, you can just read it up from the article. So, and at the end of the surgery you have to ensure that the tube is draining properly. So if it is not draining properly on the table, then it's not going to drain later on also. So be very careful about this. And these are of course some of the post-op pictures of patients where in laser conjunctival DCR was performed. And again, the disadvantage of doing a laser conjunctival DCR was, here we have not opened the sac completely. So here, since the sac was, part of it is left, so this patient developed a sump syndrome after a conjunctival DCR. So this is another complication which was not reported, and it came as a surprise to me. So what do I do? When do I do endoscopic DCR, and when do I do an external DCR? So patients who are over 60 years with heart disease, who are hypertensive, who are not very good candidates for putting too much of ADR into the nasal packs, I would go for external DCR. If done properly, the scars are not that bad, so you don't really have to worry. Post-traumatic cases, needless to say, I always do external DCR. If I need to take a lacrimal gland biopsy, there is a doubt of any malignancy or any tumor, I always go for external DCR. Patients come here, lot of patients from outside, they come here, they want to get operated, never come back for a follow-up. So remember, endoscopic DCRs, you sometimes really need to do nasal douching, you need to check up with your endoscope regarding any, how things are functioning. So those patients who don't want to come back for follow-up, I would go for external DCR. Young patients demanding scarlet surgery who are willing to follow up, I would go for endoscopic DCR. Acute cases, or patients who require septoplasty, there I don't do septoplasty, but a lot of eye surgeons are doing septoplasty themselves, but there you can go for endoscopic DCR. And another thing was that if you have a DNS, so can you do endoscopic DCR or not? This was another study that we carried out, and we found that patients where you can put in your endoscope, this is the study we did in a laser DCR, and it was till the moderate DNS where you could, I use a lens spatula to push back the terminate slightly, and you could visualize things properly. There you could perform an endoscopic DCR, but a severe DNS case, you should never try and perform an endoscopic DCR, because the more you're going to touch the mucosa, the more bleeding you're going to have on table, and the likelihood of ending up in abandonment of the procedure is far more than doing a good work. So thank you so much.
Thank you, ma'am. I think amazing set of cases, and it's nice that you published all of the complications also, so that everybody learns. Dr.
Yeah.
Anita?
That was really very, very comprehensive and a lovely presentation.
Thank you.
And so tell me now, many of those cases were when you were in an institute. Now that you're in practice, do you still follow the same? Do you find you're doing more endonasal than you were doing in the hospital?
No. There are 2-3 reasons. One is, as I said, most of my patients here, they come from far off, and they don't want to come back for follow-up. So that is one big contraindication for doing endoscopic DCRs, because endoscopic DCRs, you really need to many times go back, check with the endoscope, sometimes, revise, do a nasal douching, so you need a follow-up for some time. So here my external DCRs have become far more than what it used to be. But I am still getting a lot of complicated traumas which are being referred. So again,
Yeah, and in the endonasal, do you intubate all the patients? Do you use mitomycin?
No. In fact, we had a thesis on it. We have published in OPRS where we showed that the results were similar with intubation and without intubation. I only intubate cases where I see that the common ostium, internal ostium is narrowed. Otherwise, I never intubate my patients.
Okay, I think those are really good learning points. Yes, doctor.
Madam, endonasal is a walk-in, walk-out procedure. You don't need any further follow-up, I suppose. We have Dr. Sriya out here. Can comment.
Lot of my own students are saying that
laser if the patient doesn't come for follow-up.
yes, but
It's a walk-in, walk-out procedure.
my own student has started doing lot of the walk-in. We used to do 6-7 endonasal DCRs in one day. We used to do the same thing. But say when you come into practice, you have patients who say कि अब एक बिल्कुल कुछ होना नहीं चाहिए. When they ask you this question, then I say no, I cannot. You may require a follow-up. So if a patient who's willing to come back, if there is a problem, it's okay. If they go back to miles away and never come back, then no.
What are your indications for laser?
See,
Because you are going to do again a DCR surgery.
No.
After doing laser.
No. Actually, diode laser I was using when I was in the institution, and no, you simply make the small osteotomy with the laser, and then with the Blakesley's forceps, endoscopically, surgically, you enlarge it. So it's in one go only.
But that's going to get obliterated on a longer run.
No. We have published, and we have more than 1 year follow-ups. They don't get closed. No.
Thank you, ma'am. Next, we'll have Dr. Anita Sethi, and she'll be talking to us about eyelid malpositions.
Thank you. So I'll be talking about eyelid malpositions. This is a very vast topic, and I'm just going to give a very brief overview of how to tackle them and what are a few of the good procedures that can be done. So the normal eyelid margin position is upper lid margin covering 1.5 mm covering the cornea with the lashes out and up, and the lower lid is at the lower limbus with the lashes out and down. And as we know, any changes in this is either going to cause us entropion, ectropion, trichiasis and dystrichiasis. In both the lids, we can have any of these. To understand the surgeries, we just need to understand the anatomy, and very briefly, there is in the upper lid, there's an anterior and a posterior lamina separated by the gray line, and this is a very, very important anatomical feature while we are doing our surgery. And the lower lid is slightly different, not so well developed, but still there is a gray line, there is an anterior and a posterior lamina. And here we find that the aging changes are what results in the displacement of the eyelid. So starting with the upper eyelid, entropion in the upper eyelid is mostly cicatricial. It is due to infections, inflammatory, and can be congenital as well. Whereas ectropion is also cicatricial and because of burns and trauma. Entropion earlier used to be also a lot more due to infections, but those trachoma days are now over, so we don't see as much of that. So that earlier we used to get a lot of patients with tarsal plate thickening, shortening. Now we get more of the inflammation cases, pemphigoid, OCP, SJS, and of course, unfortunately, even burns. And apart from the supportive role, mostly we need to do surgery in these cases. Now in upper lid entropion, which surgery you do can depend somewhat on the pathology. If there is a deformed tarsus, we do tarsal fracture, which isn't done as commonly right now, but it used to be done, and wedge resection is a more commonly done procedure. So briefly, in the tarsal fracture, the principle is to rotate the lower part of the tarsus on itself. This is a conjunctival approach that I am showing. So you do a full thickness incision of the tarsus, and you take the suture from the upper end of the tarsus and you bring it out beneath into the skin behind the lash line. So you are basically rotating the tarsus upon itself. So we do 2 or 3 sutures like that, and in those days we used to keep the sutures in there for 15 days, so they're being passed through a rubber peg. This is just to allow scarring in that position so that the lid margin remains everted out. And the correction that you need to see will happen on the table. If you don't see the correction on the table, then you've done something wrong, and this procedure is not going to work. So you can see that the eyelashes have now all turned out and away from the cornea. So you know that you have passed the sutures in the correct place. The other approach, which is more common, is the surgery is the wedge resection. This is usually done when there's a thickened tarsus plate and usually some excess skin as well. So you expose the tarsus and you remove a wedge of tarsus with the apex towards the conjunctiva. Again, you want the tarsus to kind of turn away from the cornea. So this is a wedge that is made. And be careful, sometimes if you are not careful, you go. So it's about 85% thickness of the tarsus so that you don't go through and through. And as steep as the wedge should not be too steep, it should be a slanting one, so that you can get the tarsus to move away from the cornea and the margin to move away from the cornea. So after you've removed the strip, you then pass sutures to the 2 cut ends, which is how it will rotate away. So that's the sutures that are being passed. Again, you pass 2 or 3. I don't know why we were always taught 3 for everything. Nowadays, even 2 is good enough. and once again you've tightened the sutures, you'll take some, because there's always excess skin, you will remove some skin muscle, and then when you tighten those sutures, you can see that the lid margin has turned away. Cicatricial ectropion of the upper lid is again usually due to infections, sometimes trauma. You need to excise the scar tissue, and you can usually need a skin graft which can be taken from the other lid. It can be taken, retroauricular is a great match, or even the inner arm. A tarsorrhaphy is a must because this graft tends to contract, and always take about 25 to 30% more of tissue than is required. Coming to the lower lid, the position changes are usually due to aging changes and sometimes trauma. So in aging there is laxity and lengthening of the lid, and whether there's going to be entropion and ectropion depends on whether the laxity is the whole lid margin including the tarsal sling, that will result in ectropion, whereas if the tendons are still strong and there is only dehiscence of the retractors, you're going to end up with entropion. So involution entropion is a very common condition that is seen, and it is due to either dehiscence, complete dehiscence, or just weakening of the lower lid retractors, and there will be rolling of the preceptal or the orbicularis fibers, and the patient is very symptomatic and has a lot of watering and discharge. There are many procedures. I'm going to just describe the modified Jones procedure because I found that a very useful procedure and simple to do. So this is to plicate the lower lid retractors. So we have a subciliary incision, and we then identify the lower lid retractors, which are seen as a white tissue. It's the capsulopalpable fascia. And they are either dehisced completely or just stretched. So you pass the suture through the tarsal plate, and here I am plicating the retractors. Again, 2 or 3 sutures so that you don't leave any of the tissue behind. So you pass the 3 sutures and then you tighten them, and the thing is, again here you must see the lid rolling out as you are tightening it, because it's not going to do anything later. Whatever happens is going to happen on the table, so you should be careful that you have completely made sure that you have caught hold of the retractors and you have not taken any other tissue, so that you might end up getting an ectropion if you take the wrong tissues. Now coming to the lower lid ectropion, this is usually senile, or it can be seen paralytic following 7th nerve palsy or acoustic neuroma when the 7th nerve has to be removed. You can see there will be a lot of laxity, and that you can see by doing distraction or pinching test, and you do need to both shorten and strengthen the lower lid, and sometimes it's a combination. And I'm going to describe the lateral tarsal strip procedure, which is my actual favorite procedure. It's my go-to procedure for most of the lower lid. Even in entropion, sometimes after doing that I will also do this because you get a good connection. So now here you have dissected down to the lateral tubercle. You are releasing the lower crus, and you need to mobilize the lower lid so that you can shorten it and tighten it. You split the lid margin at the grey line, so that's where the grey line is so important, into anterior and posterior. So you are separating out the conjunctiva and the tarsus. You then make a strip, and you would have already determined how much lengthening there is, so that accordingly you can also decide on the length of the strip. Removing the epithelium from the conjunctiva and from the margin, and then pass a double arm suture, non-absorbable. I'm using 6-O-proline. You pass this double arm suture, this one single arm, but you can, and then you have to take it right down deep into the lateral tubercle, the periosteum, to make sure it goes into the periosteum, and always try to be a little higher than the lateral tubercle, so that with gravity there's a tendency to sag, so you must make sure you don't pass it too low down. It should be into the periosteum. That means it has to be deep and it has to be a little higher than the lateral canthus. So then it's well anchored. So you make sure that it is a good tight knot and it is well anchored. And then there is excess skin and tissue which you then remove so that you don't have any bunching and you get a very good cosmetic result. So you can see this is he had a 7th nerve palsy, and then once you make sure you've anchored it well into the lateral tubercle, then you get a very good positioning of the eyelid post-operatively. In sacatricial entropion in the lower lid, obviously the tarsus is not well developed, so you need to use, this is a Stephen Johnson's patient, you need to use grafts, and these are the more difficult cases to handle because the grafts don't always take so well. But the mucosal and the lip grafts and the cheek grafts do really well in even for the margin. In some of the cases where you have to do a marginal graft, it works, they work very well. So to summarize, in the lid position abnormalities, we always need to balance the two laminae. The upper lid is problems are usually entropion because of the posterior lamina fibrosis or shortening. And in the lower lid, it is mainly senile changes. Entropion is usually due to dehiscence of the retractors. So we must tackle the retractors if we want to get a good correction. And the lateral canthal sling is a very useful procedure because even in entropion, senile entropion, there will be some amount of lid laxity, and lid laxity is there in both entropion and ectropion. So supporting the lower lid with this procedure is always going to enhance the results of your surgery. Thank you.
Thank you so much, ma'am, and good set of very practical procedures which all of us apply in our practice. Just a couple of things. So with the conjunctival approach in the cicatricial entropion, do you always prefer that, or do you sometimes prefer the conjunctiva sparing approach?
So in an entropion, if the scarring is already there in the conjunctiva, then mostly that is where, even if you want to put in a graft, that's where you do have to approach. So yes, I usually...
Depends on the length.
Yeah, it depends on how much of length is there, and I do usually... I think you have to look at each case and see where the scarring is, and then accordingly you have to take a call.
Thank you, ma'am. Next we'll have Dr. Joyita Das, and she'll be talking about flaps and grafts in eyelid reconstruction.
Good afternoon, everybody. Thank you, AIOC, and especially Dr. Fairouz for the kind invitation. Today I'll be talking on eyelid reconstruction, flaps and grafts. Eyelid reconstruction is always a very challenging procedure because of the dynamic complexity of the eyelid, which plays a role to maintain the integrity of the ocular surface, to protect globes and expression and beauty. The knowledge of basic anatomy is very much essential for its proper reconstruction. So the eyelids are an elliptical structure. Horizontal palpebral length is measuring around 25 to 30, and the vertical palpebral height is around 8 to 10. And the lateral canthus lies 2 mm higher than the medial canthus. On the perspective of reconstruction of the eyelid is divided arbitrarily into posterior lamella and anterior lamella. Anterior lamella is formed by skin and orbicularis, posterior lamella formed by tarsal plate and the conjunctival surface. And the grey line is formed by, this is the grey line which divides the two lamella. The indication of eyelid reconstruction are many. For the congenital indication as coloboma. In the acquired causes, tumor excision, primary reconstruction or secondary reconstruction. In case of trauma and burn, irradiation, these are common indication of eyelid reconstruction. The goals of eyelid reconstruction are is to preserve the eyelid function, is develop a stable eyelid margin, ensuring adequate eyelid closure for ocular protection, maintaining adequate vertical lead height, and creating a smooth epithelial in internal surface. Reconstruction has some basic principle that once we doing the full reconstruction of a full thickness lead defect, both the anterior lamella and the posterior lamella should be reconstructed in those cases. There one lamella should be the graft and the other lamella should be flap, that they should have their own blood supply. This is the case. You can see that both the lamella, the full thickness lead excision has been done. In the secondary reconstruction, we are using posterior lamella from the other eye and the anterior lamella formed by the pedicle Fricae flap. So what is flap? Flap is the tissue that is transferred from the nearby structure to reconstruct an eyelid defect with an intact vascular supply. It has a vascular pedicle. The advantage of flaps are it provides a good blood supply, and the color and the texture also matches better than the graft. It heals more reliably than the graft and it restores eyelid function and contour. Whereas the graft is the tissue transferred to the reconstruction site of the eyelid defect without an attached vascular supply. So it can be taken harvested from the post-auricular and any other side like subclavicular for the use for this eyelid cases, and it is grafted in the eyelid defect. The common graft used in eyelid reconstruction are for the anterior lamella reconstruction, full thickness skin graft is most commonly used, and the posterior lamellar graft, tarsal graft is the most common, followed by hard palate, nasal septum and post-auricular cartilage. In eyelid reconstruction, we should remember to maintain the sufficient and anatomical canthal fixation, and we should first minimize the defect area as much as possible before sizing a graft. First, we have to do the assessment of the graft, assessment of the defect, whether it is a full thickness or a partial thickness lead defect. The lead margin involved or not, then the location should be noted, and we also have to note the canthal involvement, canaliculi status and the laxity skin. First, when we are seeing the defect, first you have to assess what lamella is affected. If only anterior lamella is affected, then it is closed by direct closure or Lee's flare, or in some cases there is healing by secondary intention, where you cannot apply any suture like the necrotic area. First we have to less vascularized area. This Lee's flare technique has been very effective. The anterior lamella, some skin local flap like VY flap, bilobe flap, rhomboid flap also used, and finally full thickness skin graft where the defect is much bigger. And in case of margin defect or full thickness defect, the size of defect actually plans the what technique we should do. If the defect is small, that is up to 25 to 50% length, then direct closure. And if it is there is much tension, then you have to do direct closure with canthoplasty. If the defect is medium defect, that is 50 to 70% of the lead length is involved, then Tengel flap and McGregor flap is a good option. And when the defect is large, in case of large means more than 75% of the length is affected. In case of upper lid, cutler beard lid shearing, Master-D switch flap, globular flap is a good option. In case of lower lid, Hughes flap and Master-D cheek rotation flap is a good option. There are some specialized flap like Fricae flap, paramedian Trippier flap, which is also very effective. In this case, you can see there is anterior lamellar defect, so direct closure has been utilized here. This is the case where we have treated with a Lee's flare or secondary intention. Only antibiotic dressing has been treated, and then followed by secondary reconstruction. This is the case of a pilomatrix summa, large pilomatrix summa in the upper lid. The anterior lamella there was a large defect in the anterior lamella. It is reconstructed by full thickness skin graft from the subclavicular area. There are some local skin. This is the rhomboid flap, where there is a basal cell carcinoma near the lateral canthus, and I have used rhomboid flap to cover the gap. There is a small video clippings for direct full thickness marginal repair. First, from the gray line, from the 3 millimeter from the defect, the needle is passed. You can use 6O Vicryl, or this is the silk suture I am using here. and it come out through the that is 3311, and the knot is tied. Oh, sorry. Knot is tied and the lamella is closed by interrupted suture, and the remaining long length of the suture should be tied finally. That it will not rub the cornea in the post-op period. Okay. When there is medial defect, the most useful thickness tangle semicircular flaps which can use in both upper lid and lower lid. The tangle flap is actually a semicircular lateral skin muscle advancement flap with lateral cantholysis. Here is a short video clipping of the tangle semicircular flap. This is a patient with a golden hair syndrome. Here first the coloboma has been freshened, then the lateral canthal tendon has been cantholysis has been done, and a semicircular lateral flap with a curve down has been taken, and then the gap is filled by vertical matrix suture. Finally, lateral canthotomy should be done very meticulously in these cases. And this is the final appearance. This is the pre-op picture of the patient where there is a limbal coloboma, with a limbal dermoid, and the surgery has been done in a same sitting along with a cornea person with a dermoid excision with amniotic membrane along with the tangle flap I just have shown. Next is when the full thickness defect in the upper lid more than 75%, then Cutler-Beer lid sharing procedure is very effective. It is Cutler-Beer, the definition is it is a full thickness flap with skin and orbicularis and conjunctiva advanced from the lower lid to upper lid under the intact lower lid margin. This is a short video clipping after excision. Just a minute. After excision of the large flap, this is the skin defect. And here we are taking the skin muscle and conjunctival flap from the lower lid, and it is advanced through the cut end, the full thickness cut from the lower lid margin, and it is placed in suture with the upper lid lamella. Here it's important to suture the LPS muscle along with the flap, so then later there will be no ptosis. And after 6 weeks the flap has been divided. This is the picture of the patient. You can see the right eye there is a large sebaceous gland carcinoma which has been excised, and after frozen section this reconstruction has been done. This is post 6 weeks after the division. Next is a mustardy switch flap. This is also a specialized flap which is used to repair reconstruct in a large upper lid defect. Here the lower lid flap is marked, the vertical length is replicated in the lower lid, but it's very important to keep that 4 millimeter margin in the lower lid. Then the edges of the coloboma here has been dissected, and the conjunctiva is sutured with a fibrin glue. Now the full thickness lower lid flap has fastened, and it's very important to keep that pedicle. Lateral cantholysis has been done. Now the vertical matrix suture is placed to repair the lower lid defect. And the upper the flap has been sutured in layers with the upper lid gap. After 3 weeks, the suture, the pedicle has been divided, and the canthotomy has been repaired. This is the pre and the post-operative picture, 6-month picture of the child. And in case of lower lid large defect, we can use Hughes flap. Hughes flap is upper lid tarsoconjunctival graft with a horizontal rotation graft. This is the photograph. This is the short video clippings of the procedure. After the excision, this is the lid defect which has been measured, and it is replicated in the upper lid tarsal plate. Here also it's important to keep the 4 millimeter margin for the upper lid stability. the lid margin, upper lid tarsal plate flap has been made, and it is now transferred to the lower lid suture with the remaining border of the tarsal plate of the lower lid in a lamellar fashion. And
Dr.
finally
Joyita,
is, ma'am,
you'll have to just
sure.
summarize.
Okay, ma'am, this is the last one I've done. Okay, I'll just skip it, the video then. This is the pre and the post-op picture. These are some of the specialized lid reconstruction technique like glaberar flap and nasopharyngeal flap we also use commonly in lower lid reconstruction. So the take clinic policies when approaching the reconstruction, a thorough understanding of the anatomy is important in planning a successful surgical approach. Selection of patient appropriate eyelid reconstruction technique depend on patient age, comorbidity, eyelid condition, defect, and of course surgeon's preference. Thank you.
Thank you, Dr. Joyita. That was really a wonderful demonstration of so many beautiful videos, very nice. Sorry we had to cut you short, we're just running short of time. So we will discuss maybe over tea and we'll just go on to the next speaker.
Okay. Thank you, ma'am.
Yeah. So next we'll have Dr. Raman Mittal, and he'll be talking to us about surgical insights in orbital surgery.
This afternoon. So thanks a lot by the organizers. Wonderful conference has been organized. Wonderful halls. We have probably the largest halls ever available in AIOC to us in oculoplasty this time.
ऑडियो भी है इसमें, ऑडियो में
नहीं ऑडियो में बोल दूंगा कोई बात नहीं. So this is a topic in which I was supposed to give you insight about the orbital surgeries. So what I am trying to show you is only one basic surgery, and most of the steps are the same, which we can extrapolate. And this is what I'm now we all go for minimal approach or minimalistic cutting and suturing techniques for all our oculoplastic surgeries. So what I'm trying to suggest is then sutureless orbital surgery for even for large tumors. Play हो रहा है ना? Okay. So because everybody wants sutureless, the patient comes and demand whether you will be doing surgeries by laser or not. Whether they understand laser has been promoted so much by our colleagues and anterior segment, the patients come and demand about the laser surgeries. So any orbital tumor which you are planning to do by orbitotomy, the main important thing is that you should know in your mind what approach are you going to have, and for that you have to know about the orbital spaces which you have around the globe. So whether it's in the superior orbit, whether it's in the lateral orbit, whether it's in the posterior orbit, retrobulbar space or whatnot, because orbit is a three-dimensional structure and not 2D, as was being mentioned earlier in the morning class by Dr. Usha Kim, that what we study is 2D is in the books, but what we encounter is 3D when we go into the orbit. So in this video what I'm trying to demonstrate is a 360-degree peritomy which is being done for an orbital tumor which was lying right behind the globe. So you do a canthotomy, cantholysis, and do a 360-degree peritomy. Do a subtenous dissection there. So do a subtenous dissection. Can give relaxing incisions to the conjunctiva, and then you bridle the muscles, especially the muscles which are around the tumor's location. So after doing blunt dissection, when you reach up to the tumor, there you see that the tumor is sitting around, and then you do blunt dissection all around the tumor gently, so much so that the tumor you can easily move. Then with the use of cryoprobe, you just make the tumor stick to the cryoprobe and gently pull it, and at the same time do the rest of the blunt dissection which is required. So you see that the tumor can be easily and very nicely extracted out of that area. It's a wonderful and huge tumor which is being extracted right from the retrobulbar space. So this is the basic steps which we can use for all type of tumors, mostly I would say most of the tumors, and then you can simply glue it down. The conjunctiva can be sutured there rather than suturing, sorry, you can glue it down, so it becomes a sutureless. So you can sort of, you can sell your surgery by saying I'll do a sutureless orbitotomy, and then you close it. So it's more of a sutureless surgery and finishes off very fast. So again, I would say for this you need to know where your tumor was lying, so your approach has to be great, your initial dissection has to be proper, the muscles should be separated and moved apart so that you can easily extract the tumors. In some cases you need to make subbrow incision if the tumor is large or sitting on the superior aspect. Even then, if you make a nice incision just below the brow, you hardly have any scars. In this patient, the tumor was lying on the medial aspect, so carancular approach was taken. Similarly, for this girl, you see a unilateral telecanthus, and in the scans you see that the tumor is there in the intraconal space, but on the medial side. So you go towards the carancular side, and then you do a similar type of approach, and you can remove these type of tumors. So most of the orbitotomies nowadays being done are not requiring cutting of the bones and reattaching them as we used to do earlier, and even now the approaches have become minimalistic, coming towards the conjunctiva rather than going outside from the orbits. So these are the post and pictures. So I would conclude by saying no more large incisions or bone cutting is required. Like phaco, mini phaco, SICS, SIOCS, they have given so many names. I do small incision orbital surgeries to way to go, and you call it as sutureless orbital surgery. Thank you very much for your attention. I think it was short enough.
That was absolutely wonderful, Raman. And I think, yes, we should all be thinking out of the box and going for different routes. Just, I think only the glaucoma surgeons may not be very happy with you doing 360 degrees peritomy. So if it is a glaucoma patient, you might want to not meddle with so much of conjunctiva, but I think most of the cases it does seem to be a fairly a good approach.
Yeah, that's a good point to be kept in mind, but 99% of the cases which we come to us is not glaucoma, but that's a good point. Thank you very much for the take. Thank you very much for your patient hearing.
So before we proceed to the panel discussion, we'll just share a quick case. I think आपने ना previous उसमें डाल दिया है, ये ना इसमें चला गया है शायद, नहीं इसी में था वीडियो.
I think a lot of us are now approaching the orbit through not the standard styloid incisions, phoneal incision, carancular incisions. So I think yes, conjunctiva is the way to go.
ऋतुजा.
So if anyone has any comments on all the talk so far, while Rituja is looking for her, have you found it?
As you mentioned regarding the glaucoma patient, yes, in those type of cases, the approach can be the same, but rather than 360 peritomy, as you are now saying, we can go for initial approach, and you can lift the flap that way. So in that way, you don't actually disrupt that area.
I was also thinking how to keep the glaucoma people happy.
So if it's in the inferior orbit, you can go for the phoneal approach,
Right.
which we do.
Right. Yes, Shalu, some comment share with us, tell us. Before the next session chucks us out.
I was just saying we can do the Burkies incision and cut the conjunctiva and go beyond, below the lateral rectus and take the retroocular tumors like this.
Yeah.
Okay. So just a very quick case to add on to Dr. Anita's talk on eyelid malpositions, case of congenital entropion. So many of these children who come with congenital entropion they don't really have too many symptoms. You can see the cornea is pretty much clear. There's no congestion. Only the parents complain of watering. This is because the eyelashes are very soft and they don't really cause too much of issues. But when they are symptomatic, we need to operate them. So how do we do it? We first put a traction suture on the lower lid and we go for a subciliary approach because eventually we want to join the lower lid retractors to the orbicularis to prevent the override. So subciliary approach, and you can go ahead and make the incision just 4 mm below the lid margin, and once you dissect out the orbicularis, if it is excessive because of the override, you can actually debulk the orbicularis as well. Once you open the septum and you expose the lower lid retractors, you need to dissect off the lower lid retractors. So that is the anterior portion of the lower lid retractors as well as posteriorly of the conjunctiva. There you can see the white band, which is the lower lid retractors. So once it's dissected off of both, you can go ahead and debulk the orbicularis as well. And once the orbicularis is debulked, then you go ahead and join it. The skin orbicularis, you can see the lower lid retractors being taken in the bite, again the orbicularis and the skin. So what this essentially does is it creates a bit of a lower lid crease which eventually fades with time, and but it gives a very good outcome with respect to a long lasting lash eversion and a lid eversion. There you can see just before the sutures are being removed. So thank you. Ma'am, if you just want to discuss.
No, that was a very good demonstration and very well, addressed. And there's very little tissue in a child, so you don't want to do just a skin muscle without actually releasing. So that is really very good. I think we are out of time. If anyone has any questions or suggestions, no. Okay. Thank you all for patiently letting us overstep the time. So sorry, Kasturi. Yeah, thanks a lot.